is selected by a group of 40 physicians in a double elimination set of runoffs. We interview about 150 physicians from every field at the Cleveland Clinic, about 20 investors or venture capitalists, and 10 from the media on 3 main criteria: what will make a clinical difference in the next year, what will make a large clinical difference in the next year, and what's important for patient care. The group meets, that is 20 physicians meet. They take the 250 or so suggestions that the staff, led by Susan Burnett, has whittled into great paragraphs and summaries, and eliminate and get down to about 25. So there are 20 groups. Then there's a single elimination after that to get the top 10 things that will make a major difference for clinical care in the next year. I think we've done this for more than 13 years. The results of the prior ones are on our website. You can see in 10 years we've only really missed one, if you will, so it's a tremendous record of success by this method. Today we will reveal the top 10 things that we think will change patient care in a major way next year. And there's a major difference this year compared to prior years. In prior years, it seemed like there was always a device or a drug. In this year, most of the suggestions were at the interface of specialties, that is, 2 things combining, as you'll see, to make major differences for next year. So let's go ahead and get started. We'll do it on a fairly tight time frame. Number 10.
Number 10, RNA-based therapies.
A code of genetic information. Ribonucleic acid has become a popular target for therapeutics. Interfering with that code gives scientists the ability to intercept a patient's genetic abnormality before it is translated into non-functioning proteins. Antisense nucleotide therapy prevents the production of proteins encoded by a disease and is being explored in several conditions such as age-related retinitis, familial hypercholesterolemia, and Huntington's disease. RNA interference, a mechanism for gene silencing, is currently being explored for use in cancer and neurological diseases. With RNA interference, RNA molecules, either microRNA, miRNA, or short interfering RNA, siRNA, inhibit gene expression by neutralizing targeted mRNA sequences. FDA approved in 2018, the most successful RNA interference therapy is for the treatment of hereditary transthyretin-mediated amyloidosis. Feeding off the success of DNA-based gene therapy, RNA-based therapy puts a twist on treatment, sparking progress and innovation in therapeutics.
Dr. Olga Stanina from the staff in molecular cardiology at the Lerner Institute will discuss this. By the way, when you ask questions, if you can ask questions, put the number, that is a 109876, before your question, which will make it easier for me to figure out who to call on.
Well, I would like to stress how important and how amazing was this discovery of RNA interference. The whole new class of molecules, of regulatory molecules, the whole new level of regulation inside the cell was discovered, and that's not something that happens every year or even every 10 years, so it's a really big discovery. But what is even more important about this discovery is its absolutely unprecedented therapeutic potential. And actually that was very quickly appreciated. The Nobel Prize was given to Craig Mello and Andrew Fire, who did not discover the first microRNA, but they showed that it's a general mechanism that can be used as a tool, that can be used to create new therapeutics. So these oligonucleotides, the therapeutic agents, they are based on the sequence of DNA, on the sequence of mRNA, and it's very easy to design them because we know the sequence of every gene in our genome. Human genome has been sequenced and many other genomes have been. So it's easy to design. It's relatively easy to deliver. In the lab, we actually just inject the naked oligonucleotide and it goes where it's supposed to be and it gets taken up by the cells. And also it can be very, very specific because it's sequence-based. Of course, it needs to be tested, but the potential of being very, very specific is very high. And that's why it's taking off, and that's why we see the new drugs appearing, and there are very many oligonucleotides in trials, in preclinical trials and clinical trials, and I think it's not just for the next year, but for many years to come.
And one of the things mentioned was that you can stop the production of proteins you don't want to, like amyloid in amyloidosis. Can you say a little more about that?
Yes, sure. So these microRNAs, they bind to the mRNA, which is used to produce the protein. So they bind to mRNA and they stop the production of protein. So by designing artificial small oligonucleotides that will bind to your mRNA of choice, you can stop the production of specific protein. And it's easy to design because we know all the sequences for each gene that results in the protein eventually.
Thank you. Number 9.
Number 9, mitral and tricuspid valve percutaneous replacement.
It beats in your chest. It pounds with anxiety. The heart is one of the most vital organs in the body and prone to an array of problems. Surgery on the heart has become less invasive, and many cardiac procedures are now conducted percutaneously via a catheter through the skin. Percutaneous surgery has been game-changing in aortic valve intervention and has now expanded to include replacement of the mitral and tricuspid valves. To remedy mitral valve insufficiencies such as prolapse, regurgitation, or stenosis, a replacement valve stent is inserted in a percutaneous manner. Performed for the first time in 2016, the world's first implantation of a tricuspid valve stent has shown excellent maintenance of valvular function. The exploration of this technology is ongoing, but with promising results, the innovation lowers risk and improves care for cardiac patients.
Dr. Samir Kapadia, who is director of the cath labs in the Heart and Vascular Institute at the Cleveland Clinic, will discuss this.
Thank you very much. First of all, thank you for recognizing the heart is very important, and we all are very, very excited about the fact that for the first time we are able to treat not just the aortic valve but the mitral and tricuspid valve percutaneously. We replace and repair. Both have seen the advancement in the last year, and the most important fact that we understood is that patients who come with heart failure, where the heart is failing and the mitral and tricuspid valves are leaking, not because the valves are abnormal, because heart is dilated and the valves are leaking, treating the mitral and tricuspid valve in these patients not only saves life, but also makes them feel better. They do not have hospital admissions, and this is a very crucial part. So this is going to improve our abilities to expand the indications to all these patients. And now there are several therapies, including the first one we did for the first time, not in the world, done in Cleveland Clinic, because this is unusual that FDA allows us to do the first valve replacement. So the tricuspid valve replacement was done first time in Cleveland Clinic, 2016, patients still doing well. And this is now done in 30 more patients, and it is going to be available for patient use in the near future, the tricuspid valve replacement. And the mitral valve repair, as you know, the mitral clip is now also at a level where it is routinely used. We do 2 or 3 cases every week, and it may get FDA approval for the indications for heart failure. So this is a big advancement for the patient care and for the interventional cardiologist treating valve disease.
Heart failure is an expensive thing to treat. They keep coming back and back many more times. Will this just add to the cost?
Actually, it may help with the cost because although all the therapies, of course, is done for business, so people want to make money, so there will be some cost initially involved with the care, but only 3 patients if we treat, we prevent a hospitalization in 2 years. So we have to treat only 3 patients for MitraClip to prevent a hospitalization. So as these therapies become more effective, safe, and without risks, we will probably be able to decrease the cost and also make people feel better. So this is a huge improvement for patients who are looking for options when they have heart failure.
So fewer hospitalizations for heart failure patients because of this.
Exactly.
You're free to send in questions at any time. You don't have to wait to the end. Number 8.
Number 8. Innovation in robotic surgery.
An extension of the physician's hands, robotic surgery provides pinpoint accuracy. Advances in the field range from the development of more accurate planning tools and software to increased automation of tasks during surgery. Precision surgical arms designed for proper instrument positioning and implantation during spinal surgery increase surgeon precision. Automating the bronchoscopy process avoids incisions with the insertion of flexible tubes through the body's natural openings. Using a controller-like interface, this advancement increases accuracy and safety while decreasing invasiveness and cost. Robotization is also reaching endovascular procedures like percutaneous coronary intervention, PCI, and peripheral vascular intervention, PVI, which traditionally require the surgeon to wear lead. Using robotics now lowers risk for patients and the surgeon while improving outcomes. Robotic surgery provides precision, flexibility, and control. Paired with shortened recovery time and limited pain, patients benefit from the continued advancements in the field.
Dr. Jihad Kayuk, who is the director of robotic and imaging surgery and part of the Glickman Institute, Urologic Institute, will discuss this.
Thank you, Dr. Roizen. Robotics by itself is not new to medicine. It's been there since the year 2000 and applied frequently every day all over the country. What's new is really the spread of robotics, spread all over the subspecialties. You saw several examples today in the movie presented. It moved from being in the operating room mostly for urology and cardiology into fields that were not there before, like pulmonary, doing endoscopies, or for stereotactics and orthopedic surgery, as you saw in the clip there. So really, that's what's new. It's opening new dimensions for caregivers to explore. And I think we're still in the early phase of robotics. We're just touching into this vast field. And I'm not talking about technologies that are science fiction. I'm talking about technologies that are available, some of them on your phone, some of them on many aspects that you deal with every day. And the first task would be obviously to put some of these applications together to enhance what we have in robotics today. The robot today is just an extension of the surgeon's hands and eyes. What we want to reach is a level where the robot helps the surgeon and the surgical team to explore and deliver more precise procedures. So you saw a robot that have multiple arms to do a procedure. Just a few weeks ago, the Cleveland Clinic received the first in the country robot that allows these multiple cuts needed to enter the patient and do the surgery. Now we can do through one small incision and get all these instruments through that small incision and spread inside the patient to do the same surgery. So obviously, we're going into less and less invasive ways that mean less pain, quicker recovery, and less hospital stay for our patients. So we're just starting, and hopefully we'll be able to present more and more of this and more innovations to come.
So one of the things you told me right before we went on is that you're in fact able to do things faster with the augmented robot. Can you describe a little bit on that?
Yes, so there are different aspects that we can add to that current robotic surgery. One of them is for us to know exactly where are we inside the patient. Where is the instrument in relation to the tumor you're trying to remove? So stereotactics and having the importing of a previous image into the field where you are can guide you better, so you can do faster procedures and more precise procedures. But also there's another dimension. I can tell you that you can print, for example, an organ and get that replica of that print, put it on a bench, and rehearse your surgery a day before or so, and get your best performance to give to the patient the next day, for example.
Number 7.
Number 7, visor for pre-hospital stroke diagnosis.
The timing of stroke intervention is crucial. Those seconds hinge on the importance of a rapid diagnosis. Utilizing ambulance drive time, engineers have designed a visor for pre-hospital stroke diagnosis, a non-invasive bioimpedance spectroscopy device that detects changes in distribution of cerebral fluids. The visor is able to reveal pathologies in the brain during neurologic assessment. When on a patient's head, the visor emits low-energy frequency waves through the hemispheres of the brain, detecting changes in frequency between the two. If the frequencies are different, they indicate the occurrence of a stroke. The greater the difference, the greater the stroke severity. Studies show the visor has a 92% accuracy rate. The device received FDA 510(k) clearance in January and is expected to be commercially distributed and used next year. With stroke, they say time is brain, and implementation of the visor is poised to save both.
Dr. Mark Bain, who's Director of Cerebrovascular Surgery in the Neurology Institute, will discuss this. Mark?
Yeah, thanks, Dr. Roizen. I'd also like to say the brain's pretty important, too. Heart's important, brain as well. So I'd like to just give a little perspective here. We all in this room know that stroke, affects probably around 800,000 people per year in this country. And we, in 2015, have had multiple randomized trials that have shown that when we do procedures to take blood clots out of arteries in the brain, or do surgery to remove blood clots in the brain, people do better. In fact, it's some of the strongest data that we have in medicine. Basically, it's a 2-to-1 needed to treat to help a patient that's having a stroke. One of the frustrations we have as physicians and probably as hospital systems are that we're not getting all the patients. And one of the reasons for that is it's hard to diagnose stroke in the field. In Cleveland, we're lucky we have a mobile stroke unit that attempts to do that, and it does that very well. We can get imaging on an ambulance and tell if somebody's having a stroke. But in a lot of communities, a lot of rural centers, we can't do that. This visor, I've actually talked to the people that are working with it. There's some group in New York City that's working with it, and it's pretty amazing. 92% accuracy rate can tell if you're having a large stroke or a large bleed in the brain. And the nice thing about that is then we can organize our stroke systems so that we can get patients to hospitals faster so that we can treat the patient. So I think over the next, definitely year or two, you're going to be seeing this visor on ambulance units that are going out into the field and treating patients.
Will it replace the ambulance? In other words, will you need mobile stroke units if you have this visor? And is the visor going to be inexpensive enough to put in every police car or every first responder?
Yeah, I don't think it's going to replace mobile stroke units. I mean, that's really the holy grail, is getting an ambulance with imaging capabilities to the patient. But obviously, there's limitations to that. You can't, take an ambulance everywhere in Cleveland or everywhere in America. And so the goal of this is to get this as inexpensive as possible and to have this just like an EKG for the heart, or to have it on all ambulances, have it in shopping plazas. So if someone falls or has symptoms, you can put that on. So it's absolutely the intent.
So maybe you and the defibrillator group in Heart will join and have them together.
They're both important.
Both.
Number 6.
Number 6, virtual and mixed reality for medical education.
Imagine peering inside the human body without an incision or a scope, turning the heart without touching it. Using a headset, controllers, and innovative technology, it's possible to navigate human anatomy through virtual and mixed reality. These realities can provide medical training in procedures, techniques, and equipment use, as well as simulate patient interactions in a more immersive and realistic way. As the VR/MR trend grows, pilot programs involving these technologies for the education of medical students are being implemented worldwide. Though not a replacement for hands-on practice, virtual and mixed reality are increasing situational experience. Giving students an opportunity to practice with computer simulation is a low-risk alternative and, in extreme cases, can prevent patient harm. The technology's new applications have many dubbing virtual and mixed reality the new reality.
Dr. Neil Mehta, a physician in the Education Institute, will discuss this. It looks like from the pictures you've already been doing this.
Yeah, we've been doing this for almost 2 years now. First of all, let me reassure you, I'm not a hologram. I'm real right here. So, as you treat medical problems or you do various procedures that we have looked at, you can easily understand that understanding the 3D relationship between various structures in the human body down to the microscopic level is critical. And this becomes very important as the structures are often difficult to see. For example, the neural pathways, or the inside of the ear, or down to microscopic levels like the structure of drugs and the receptors. But mixed reality and virtual reality really lets you do this in a very unique way. Medical education, like my mentor, Dr. Young, tells me, has not changed, and he's a historian who has studied this. It has not changed in 300 years. We usually,
Was he there to see that?
So we have a lot of physicians in the audience who will probably be nodding. So we usually spend 2 years studying books in classrooms, trying to understand why we are learning what we are learning, and then the next 2 years trying to remember what we learned 2 years ago and apply it to real patients. Can you imagine that if you're trying to understand a case of Parkinson's, and again, I'm using Dr. Young's example, you are sitting in a classroom with a group of patients, you actually see a virtual patient with the typical gait and the typical tremor. Now you want to dig down deeper, you can see the structures in the basal ganglia. And you dig down deeper, you can actually see the structure of the various chemicals and the receptors and the 3D anatomy. All of it working together with a facilitator in the same classroom or remotely. You can do this. The other thing I'd like to stress is all of us who have seen patients or been patients know the importance of imaging. Nothing happens in the hospital, it seems like, without a CT, an X-ray, an MRI, an ultrasound, an echo, what have you. And our students, instead of learning radiology right from day one, have to wait till they get to the clinics to learn this. What we can do now is when you're seeing a patient, you can take their actual CT scan, superimpose it on the patient. So the patient's complaining of pain in the right upper quadrant. You can actually see the CAT scan of the right upper quadrant at the same time as seeing the patient. So as we train the physicians of tomorrow, I really strongly believe that there is seriously a chance that VR and MR may actually help us prepare them for the medicine of tomorrow like we have not done for the past 300 years.
One of the things that we enjoyed, if you will, in first-year medical school was the formaldehyde smell of the anatomy lab. Is that going to be done away with?
A great question. I think that's what we are looking at right now is what is the role of the actual physical cadaver and the experience. Clearly, most of us remember it as our initiation into medicine. And, there's a lot of things you can discuss besides anatomy when you're doing a dissection on a real human body. Do you need to do that for 2 years? Can that experience be customized to meet the learning objectives that are best taught with a cadaver, with minus the formaldehyde, because we use fresh cadavers, as Dr. Drake would stress. And then can you actually think about what do physicians of the tomorrow need? Most of us who have done a surgery residency or helped in surgery will tell you most of what you learned about anatomy that was relevant was done on the human body that was living. And our previous CEO used to say everything he learned about cardiac surgery and valvular surgery was learned during fellowship. And so what does the cadaver training actually give us? I don't think we have the answer.
Number 5.
Number 5. Patient-specific products achieved with 3D printing.
Secondary operations and poor patient outcomes result in millions of wasted dollars each year. The use of incorrectly sized implant devices has been linked to a host of problems, ranging from general irritation to migration, low function, and complications. To remedy some of the disappointing results, healthcare is investing in three-dimensional or 3D printing. Utilizing this technology, medical devices are now matched to the exact specifications of a patient, showing greater acceptance by the body, increased comfort for the patient, and improved performance outcomes. Some new and noteworthy work includes customized airway stents, external prosthetics, and cranial and orthopedic implants. Another application of 3D printing in healthcare is the printing of a patient's anatomy as a visual aid for surgical planning. The ability to hold a physical model gives surgeons the ability to conceptualize the ideal course of action prior to operating. With its widening healthcare applications, 3D printing has become a trendsetter in customizing patient care.
Dr. Tom Gilda, who is head of the, or director of the bronchoscopy unit in pulmonary medicine, will discuss this.
Yes, Dr. Roizen, thank you. 3D printing as a tool is a remarkable tool. And for the better part of 20 years, we've been looking at figuring out ways to use it in healthcare and healthcare delivery systems. We're looking at everything from drug deliveries to replacement parts, even to organic, creating new organs. The work that we've done in my section was really related to addressing probably the most common problem among patients is that everybody tends to be different. And when we're facing problems related to anatomic structures, where the diseases may manifest differently in every different human being, we've been able to take that patient's CAT scan, generate a three-dimensional prescription based on what we think the right outcome of this patient should be, and replace it with a device that was made specifically for that person, a patient-specific implant. In doing so, we've certainly revolutionized the way we take care of these patients. So where we used to spend a lot of time dealing with the complications of airway implants and dealing with the complications related to infection and migration and granulation and the like, changing out that device, one that was specifically made for that patient, has been remarkable. We've had enormous support from the FDA, and the FDA has begun to understand and appreciate how to work with patient-specific products, and we're looking forward to taking this further.
Now, one of the things you told me right beforehand was that instead of putting a stent in, if you will, every 40 days or 44 days, I think it was, you went 400 days. So that must be a great benefit to you and the patient, helping that patient that way.
Exactly. So the complication ranges that we deal with now, again, dealing just with the stents that we have, that were mass-produced, I would have to take them and cut them and sew them and fashion them for that patient. And in doing so, we were able to take what was a repeated procedure, general anesthesia operation with rigid instrumentation, and change that device every month.
Major procedure.
Major procedure every month. And then when we found a device, we used the 3D printing to make a device specifically for that patient. It lasted over a year. And again, the only reason we took it out is because we told the FDA we'd take it out in a year and plan for a new one. So this ability to impact patient lives directly with technology specifically designed for them certainly is going to have great hope going forward within many different specialties.
Number 4.
Number 4. Advances in immunotherapy for cancer treatment.
Using the body's own immune system to fight cancer isn't something new, but its advancement towards a cure for cancer is. The market for immunotherapeutic cancer therapies has seen an unprecedented number of FDA approvals. One of the most notable advancements is joint therapy, the integration of immunotherapy and chemotherapy. In a sample of patients with metastatic, non-squamous, non-small cell lung cancer, joint therapy has been incredibly effective, more than doubling the cancer response rate from its rate with chemotherapy alone. Other innovations on the immunotherapy front involve therapies derived from T cells. New forms of engineered T cells have exhibited enhanced anti-tumor activity targeting antigens on tumor cells, allowing the body's immune defenses to attack the cancers within a patient. The agent with the most promise in 2019 is that of a T cell receptor, TCR, T cell therapy developed for use in liver cancer, the world's third most deadly. With a near-daily discovery of new immunotherapeutic targets, it is the hope that effective therapies will soon exist for all tumor profiles.
Dr. Hedy Caraway from our Taussig Cancer Institute will discuss this.
Thank you so much for allowing us to be here today and to talk about this type of therapy for our patients is incredibly meaningful. As many of you know, lung cancer is a horrible diagnosis for any patient, and this type of therapy has and will continue to transform the treatment not only for lung cancer but for many of the cancers that are out there. I think this therapy in particular has been important for renal, for bladder, for melanoma, and of course liver cancer, a disorder that we really have not had much headway in for decades. So this type of therapy really pushes the envelope in helping us to understand how a patient's immune system can help eradicate cancers. This is pretty exciting to be a part of and to actually witness.
So it is joint therapies rather than one. We gave, in fact, the first immunotherapy, I think, as a top 10, probably 5 or 6 years ago. I'm reminded on Rolling Stone magazine in 2001, there was a picture on the cover of the head of immunotherapy at UC Berkeley at the time, who had failed their drugs. All the immunotherapy drugs had failed because they were only given one-year trials. His company was going belly up, if you will. He had a company as well as being at UC Berkeley. And so he said, well, let's just continue it. But he was on the cover singing the immunotherapy blues, if you will, on Rolling Stone. He recently said the joint therapies are going to take, for example, malignant melanoma from a chronic disease, cancer is a chronic disease, to a totally curable disease in 80 or 90%. Talk to us a little bit about joint.
Gosh, I hope so. I think we have some refinement yet to still do, not only in the way that we want to deliver these agents, the ordering of these agents, and even the subpopulations that matter with regard to genomic information, expression of particular ligands like PD, PD-L1, EGFR, and other mutations that then target a whole totally different pathway. So I think genomic information, selecting the appropriate patients to give them the right therapy, and equally important to spare them therapy that's going to add toxicity and not benefit. The ability to eradicate minimal residual disease, I am optimistic that the patient's own immune system probably is poised best to harness that desire, and we hope that that will happen in the future.
I'm just going to add one more point. He said, in fact, because of the differences in genetics and the way drugs are approved in the United States, we're running out of patients for trials, and we need all of you and all of us, if we, God forbid, get these diseases, to sign up for clinical trials, because that's important in advancing the field.
Thank you for that point. I couldn't agree more, especially in the world of oncology. Clinical trials are paramount.
Number 3.
Number 3. expanded window for acute stroke intervention.
Slurred speech, arm weakness. These are signs your loved one is having a stroke. Then you think, time. With a death rate of 2 million brain cells per minute, prolonged lack of blood flow can cause irreversible damage, resulting in loss of brain function and disability. Until now, the 6 hours after stroke onset were thought to be the period of time during which intervention was most effective. However, new research suggests that the window for intervention may be longer. New guidelines released by the American Heart Association and American Stroke Association in January 2018 recommend an increased treatment window for clot removal, expanding eligibility for this intervention. The recommendations came in light of results of the DAWN and DIFFUSE 3 trials, which illustrated the benefit of mechanical intervention up to 24 hours after onset of stroke. This expanded window for acute stroke therapy is changing practice and benefiting patients around the world.
Dr. Shazan Hassan, who's Center Director in Cerebrovascular Interventions in the Neurologic Institute, will discuss this.
Great, thank you very much for having me. And for those of you keeping score, that's 2 for the brain and 1 for the heart. So. No, and as was already discussed, again, we do recognize, of course, that, again, the mantra in stroke has been time is brain. Certainly we want to treat people very, very quickly and get them to medical attention as soon as possible, but we do run into situations where, unfortunately, the patients don't present in the short time windows we have for some of our acute stroke therapies. For example, if someone's found down, they went to sleep the night before and had their stroke while they were sleeping, we may not be within those time windows. And unfortunately, the time windows were limiting the ability for us to treat a lot of patients. So we used to have this 6-hour window, which was what the original clinical trials that proved the thrombectomy therapy did. However, now with these new trials that have shown, we've actually now been able to expand this window. And it comes down to selection of patients using advanced imaging techniques with CT as well as MRI. We're able to select those patients that really, even out further, have brain to save. So now we can go 12, 24, even after 24 to 36 or even more hours, picking out those patients that really can benefit from the therapy. And as Dr. Bain had mentioned, we're talking about a number needed to treat of 2, which this is probably the most effective treatment in medicine, short of the medication to treat lice.
One of the things was TPA was advanced. For those of you who don't know, the person who pushed TPA to the brain, Justin Zivin, Dr. Zivin died this year, but he had to fight with both the FDA and NIH to move it from the heart to the brain. It's also been a fight to use both TPA and, if you will, mechanical interventions for the brain. Do you see, is there an advantage of the mechanical over the TPA, or are they used together? How do they fit together? TPA, by the way, is a clot dissolver, sorry.
Right, correct, a clot buster medication. We've largely viewed the 2 therapy as complementary. So when you're within the window for IV TPA, which is recommended in the guidelines up to 4 hours after symptom onset, we do like to give that TPA medication, but we have to recognize its limitations as well, that for very, very large clots, which these ELVO or emergent large vessel occlusion type strokes are, the TPA, if you give it through the intravenous, it's hard for that medication through the intravenous to really eat away at that clot and dissolve it up fully. And so thrombectomy really has come along and allowed us now to be able to treat these most severe of strokes, getting those clots removed out of the blood vessels. And it's really nice to see now that we can really move this therapy and treat patients well further out than we could ever treat with IV TPA.
And so this changes the disability rates from strokes.
Absolutely, yeah. Again, with these numbers needed to treat, we're seeing a lot more patients, improvement in their functional outcome, their ability to return to home, to work, and to function. We're talking about patients that normally would end up with a really large stroke that would either kill them, it'd be fatal, or leave you with severe, severe disability. Remember that stroke is the #1 cause of medical disability around the world, and so to be able to have this treatment that can prevent that severe outcomes that we see from stroke is really a big step forward.
Number 2.
Number 2, the advent of AI in healthcare.
In this age of technology, artificial intelligence knows no bounds. Once thought a futuristic threat to humankind, AI is changing and saving lives. Not intended to replace clinicians or clinical judgment, AI serves the purpose to enhance and complement the very human interaction of provider and patient. In healthcare, AI is changing the game with its applications in decision support, image analysis, and patient triage. With their ability to reduce variation and duplicate testing, decision support systems quickly decipher large amounts of data within the electronic medical record. AI technology is also taking the uncertainty out of viewing patient scans by highlighting problem areas on images, aiding in the screening and diagnosis process. Artificial intelligence helps with the issue of physician burnout by collecting patient data via an app or text messaging. Chatbots now ask patients a series of questions regarding their symptoms, taking the guesswork out of self-diagnosis and saving both the patient and provider time and money. With the AI integration, working smarter enables solutions to a variety of issues for patients, hospitals, and the healthcare industry.
Dr. Ed Marks, the Chief Information Officer of the Cleveland Clinic, will discuss this.
Great. It may not be hearts or brains, but AI will help maximize the value of all the different innovations we've been speaking about. What's great about AI, it has the opportunity at the Cleveland Clinic to really impact all four areas that are so important to us, whether it's the caregiver experience, the patient experience, the community, or the organization. But what's really exciting is what we can do for the patient experience. So this morning, I was with our development team, along with our Epic development team, where we're talking about the patient triage. So the patient can self-triage, and it's all powered by AI, and to the point that they may be directed to come in for a consult, and then everything's automated. So the system knows what kind of physician they need to see, maybe who, by specialty, by a very specific subspecialty, who they need to see and what tests do they need to have before they even make a phone call. And so the time to treatment is much quicker. The patient is more engaged. And then on the clinician side, make everything easier for the clinician to help bring together information ahead of time so that the clinician doesn't have to spend their time digging for information, but it's presented to them, and then assist them along the way as they go through the diagnosis themselves and for the treatment. So from a quality perspective, from a pure patient experience perspective, and from a caregiver burnout perspective, AI is really a game changer.
Now, one of the things we were promised with the electronic medical record, it was going to give us more time to help be with the patient and motivate. Instead, what it's given us is more time to spend on a keyboard. It's said to be the leading cause of burnout. Whether that's true or not, before we get into that argument, will this improve our time? Will it make us physicians more efficient?
I believe it will. We've seen sound results early on with pathology and in radiology and dermatology, where through the utilization of AI, we can help prioritize use cases that need the most attention ahead of time so we can be more efficient in our workflow. And then some of the things that would have, we talk about operating on top of license. Some things can be handled by the AI, but we call it, an important differentiation for us is we call it augmented intelligence, not artificial intelligence, because we will never replace the clinician, the empathy, the touch that we give to our patients, because that's what differentiates us here at the clinic.
Now, one of the things you just mentioned was images and image reading, which is so difficult to pick out cancers, et cetera. Where are we in that with this?
Yeah, so we work very closely with our Imaging Institute, talking about a lot of different strategies that we're planning on employing. Definitely, there's other examples in the industry where there's been a lot of success, good track record. So we continue to work together to start doing our own rollout of that. And we believe that through the literature that we've seen and through others' experience that we have a great opportunity. So you'll see that coming here shortly.
So that's detection of images by a machine and then reread by a physician rather than a couple physicians.
Right, and then it would be reprioritized. So we have 24/7 coverage, and some things that are low acuity that we don't think require immediate attention, those would be prioritized lower than things that require immediate attention. Because today we might look at we get all these inputs at the same time and we go through sequentially, but that's probably not the best method in terms of caregiver burnout nor from a patient experience. So it automatically prioritizes those that need to be read quicker than others.
Number one,
Number 1. Alternative therapy for pain. Fighting the opioid crisis.
Nationally, the opioid crisis claims 116 lives a day. The death rate from the opioid-related overdoses has been declared a health emergency. 20 to 30% of patients prescribed opioids for chronic pain misuse the drugs, with potentially detrimental consequences. Given the human suffering and economic costs, every incremental solution to the opioid crisis is welcome. One important element to consider is genetics. Just as one's genetics influence, for example, eye, skin, and hair color, so too do genetics determine an individual's ability to metabolize drugs effectively. Pharmacogenomics, the study of how genes affect a person's response to drugs, is an excellent tool to individualize prescription pain medications. With pharmacogenomics, prescribers will be able to determine how a patient metabolizes their prescription and guard against potentially dangerous adverse drug reactions. Pre-prescription testing can also be used to determine which patients won't respond due to their genetics to some opioid-based drugs and point toward a more effective treatment for each patient's pain. In 2019, with increased access to genetic testing, pharmacogenomics is poised to make significant inroads into precision medicine and a solution to the crisis.
Dr. Jennifer Hawkins, a PharmD in the Genomic Medical Institute in Lerner, will discuss this application of pharmacogenetics.
Well, thank you, first of all, for having me up here. It's an honor to be up here with such distinguished individuals. Pharmacogenomics essentially uses a patient's genetic makeup to predict response to medications. And by having this information before a prescription is written, we can predict and select who may have adverse effects to certain medications, who may not respond to certain pain medications. That gives us the unique opportunity to select a medication that the patient will respond well to. And what's important to note about pharmacogenomics is that this information can be used for a lifetime, and it can be used not just to help with pain management, but also can be used in medications that are used to treat depression, nausea, and certain infections. In other words, the way I kind of see pharmacogenomics is that this is about getting the right drug at the right dose to the right patient.
So we had a number of submissions over the years of 3D printing, of advances in robotic surgery, for example, and in pharmacogenomics. The group felt that this was the year that it was going to take off. Is that right?
Yes, I think that we have to be careful, and because in that pharmacogenomics, by saying that it could potentially solve or cure the opioid crisis might be a little bit of an oversimplification. But I think what pharmacogenomics can really do is predict who will experience severe adverse effects to certain pain medications and who may not have pain relief from certain pain medications. That allows us to prescribe medications for that particular patient and minimize and potentially eliminate unnecessary or ineffective prescriptions out there.
And conversely, if someone requires more pain medication, you may know that.
Yes, and so one of the points that I always emphasize is that for patients who are not responding to their pain medication and they go through their medication very quickly, they may return sooner than expected asking for a new one. And unfortunately, sometimes we ascribe unfairly to these patients that they may be drug seeking, when in fact their genetic makeup may not allow them to respond to that particular pain medication we've given them. And this allows us that unique opportunity to then select a different medication that would work better for that patient.
There are other things that the group looked at combined in this area of helping to solve the opioid crisis, including food choices, other medications, aromatherapy, stress management, shared medical appointments. All were grouped together because it is felt that the intensity of effort plus the pharmacogenomics will, in fact, help solve this, or at least turn this problem, not solve it in 1 year, but turn the problem into a solvable one soon. Please do submit questions. So the first one, if you will, goes to number 8, robotic surgery. And I wanted to get your attention, Dr. Kayuk, which is, how do you see the advancement of autonomous robotic surgery versus telemanipulation, the analogous to self-driving cars versus driver assist?
I think both ideas are a step forward. I think that automation is coming because, you know, the day of having the surgery done just by bare hands and bare eyes, if I may say, may not be acceptable in the future. So automation allows the machine to help the human during doing a task. And you see it all around us with what we do during our day. So it's coming to our operating room and the procedure room soon.
And the visor, where does this stand for working with the DoD, and is this related to, can you relate this to wartime injuries? Did it develop there?
Yeah, I mean, I think it has great potential for that. Anywhere that there can be a difference in fluid in the brain, this has a potential to work. So trauma, hemorrhages, stroke, brain tumor. I think, you know, stroke is a hot topic right now, so that's why it's been focused in the stroke space. But I think it has for military use, for soldiers, for anywhere you can get this device, which it's going to be widely applicable. I think it's a great idea.
I'm going to ask the final question, unless there are more, but this one relates to a model. So is it possible to do a 3D model of, for example, a prostate with a tumor, and our expert, Dr. Kayuk, practicing on that model and then making it an autonomous robot that makes the surgery faster?
Yeah. So I'll take that, but I think the urologists are right here next to me. So essentially, almost, if you think about imaging, what we do is take 3D images with CAT scans and MRIs, but to look at them, we are actually slicing them and then displaying them on a 2D screen. But the image is actually 3D. So what we can do quite easily now for things that have high contrast, like CAT scans or studies with contrast, bones, those are relatively, I can do it in a few minutes myself. You would not, there's software that will help you do that. MRIs are trickier because of the multiple grayscales, but yes, people do that. The same thing with neurology. MRIs of brain tumors, you can create models. Once you have the model, you have two options. One, you can 3D print them, but that is a slower process right now, expensive, slow. But you can just visualize it in a VR or MR and save time.
Dr. Kayuk?
I think that the 3D printing will compete with simulation in education. So now, sometimes we train our residents and fellows by having a simulation, and it's all virtual. They're doing the surgery through like a game, like a video game that you see. Well, now we can actually print the organ, put it on the bench, and the trainee will sense the robotic instrument or the endoscope or whatever you're using in more reality-based to teach them. So I think that's going to be a competition with simulation in the educational field.
I want to thank you. I also want to especially thank the staff of the Innovation Institute that did the preparation of all 250 summaries and has gathered the group here, and especially you for staying so long and helping us motivate ourselves to do better.